Well, you've got it tuned into the Zealous Podcast. I'm your host, Rocky Snyder. This week I've got Nick Rolnick on the show. He is a physical therapist, but also the owner of the BFR Pros. BFR, of course, standing for blood flow restriction training. And we're going to dive deep into what that's all about, why people are using it for rehab, athletic training, and a whole bunch more. So I hope you enjoy the show. Be sure to follow us on Instagram at Rocky_Snyder. Click subscribe, and here we go. I would love for you to educate me in blood flow restriction, like from soup to nuts, from how you got started with it. You've got a DPT, right?
Yes. So
Where'd you
I
go to
have
school?
Columbia University
Nice.
up in New York City. And that's where I currently live right now.
Yeah. Nice.
Yeah, I mean, I guess for background information for people that don't know who I am, my name is Nick Rolnick. I am a physical therapist and personal trainer, although I would say I'm a personal trainer that's a physical therapist. I think that mantra suits the way that I approach physical therapy, in that the more and more I learn about exercise and the more in depth I get, the more convinced that the way that I practice is the optimal way to practice, whatever optimal means. But all that means to me is that exercise is the primary therapeutic target, whether you're healthy, whether you're injured. There was something that I came across a couple of years back that basically is like physical therapy or rehab is just training while you're injured. And I think that physical therapists, by and large, miss the boat on that and give up a large portion of our expertise in favor of passive therapeutics that probably don't do what we think that they do. And that kind of has spurred my interest in blood flow restriction, because I'm an amateur competitive bodybuilder, or I was back in the day. And I first came across BFR as a way, and somebody in the gym actually was tying straps around their arms and was like, oh, this is used to get a massive pump and can get muscle on and squeeze out every last little bit of hypertrophy. And as a bodybuilder, anybody's bodybuilding that's listening knows bodybuilders, especially the really competitive ones, are going to do anything they possibly can for gains. I mean, like 3 years ago, there was this craze about breast milk and the shortage of breast milk because bodybuilders were buying breast milk online because of the hormones that it had in the milk. So that was kind of my introduction along the same vein of like, all right, well, I train heavy. I'm kind of nursing a little bit of forearm issues. Let me see how it goes. So I begrudgingly put it on, and by begrudgingly I mean, it's just annoying to put on, at least back in the early 2012 ish, so a little over 10 years ago. And it was all straps and stuff. So I kind of picked it up, put it back down, and forgot about it until PT school. And I saw in PT school an article or so, and then around the same time, like Dwight Howard, there was a segment on ESPN about BFR being used to keep Dwight Howard on the basketball court. And at that point, I started to really look with a very critical eye on what exactly is this blood flow restriction. And I saw a lot of potential. I think that when I first started kind of getting into it, there was a lot of like weird speculative things that are going on with BFR. It could be magic, we could be biohacking the system and whatnot. But I kept on posting the research that I would read as a way to keep myself accountable. So I started posting on social media, Facebook, Instagram. And of course, when any new thing comes out, there are going to be tons and tons of critics. And I mirror that with, I don't know what your thoughts are on crypto and Bitcoin, but I mirror it in the same way. in that it hasn't really had the proof of concept back in, this was like 2016, that I started to post on Instagram. And people were trolling me all the time, but I still kept at it, started to read, started to convince myself a little bit more. And lo and behold, 5.5, 6 years later now, BFR is exploded into mainstream because all of these anecdotal stories that people were reporting about using BFR with their clients that are healthy or their patients that are injured, they're making unbelievable gains. And now these gains are becoming more and more supported by peer-reviewed journal articles. And so now I barely get any trolls, which is unbelievable. Just to see the quick, if you look at 6 years, but 6 years in the grand scheme of time, things is pretty quick. It's really nice to see how BFR has now found its niche or niche. I always can't pronounce that word correctly.
Yeah, chasm, I don't know.
Yeah, the optic chiasm.
That's it.
Yeah, but yeah, no. So that's kind of the nuts and bolts of how I started getting interested in BFR. And for those that are still listening, being like, BFR, what is that? Basically, you take a strap or a pneumatic cuff that's akin to a tourniquet, and you apply it on the proximal most part of your arm or your leg. And you use some form of technology, whether it's a Doppler ultrasound, whether it's built-in technology, using a pulse pressure sensor, things like a blood pressure cuff, for example, have that, like an automated blood pressure cuff has that. And what we're doing is we are, in essence, taking your blood pressure, right? If we use the cuff that's the same width, it's basically, that's how we standardize the stimulus. And then we exercise with very little load, using, anywhere from 20 to 40% of the 1 rep max, or exercising less than 50% of your VO2 max.
Well, say that again. Say that again. You're 20 to 40% of your 1 RM rep max.
Yeah. So what BFR does is, because we're reducing blood flow to the limb, we are reducing oxygen delivery to the exercising muscle. And as a result of that, there becomes this shift in energy metabolism that's more geared toward anaerobic metabolism. And anaerobic metabolism creates these byproducts, what we would call metabolic stress. But as a result of the lack of oxygen relative to a free flow condition, the type 1 muscle fibers get prematurely fatigued. And in order to maintain the contraction, then the type 2 muscle fibers have to get recruited earlier than they normally would in order to meet the force demands. And they get stimulated through mechanical tension. And that metabolic stress, that is a byproduct of the restriction of arterial inflow and the occlusion of venous return, even temporarily, anywhere from 4 to 10 minutes in resistance exercise, creates this very anabolic environment for the muscle. And we know this because BFR, in essence, does the same thing as normal strength training with low loads. Now, you can get into nuances with heavy loads and whatnot, but I would argue that it all boils down to mechanical tension. Everything, or the vast majority of things that we observe in practice and in research, can boil down to mechanical tension at the muscle fiber level and things that augment that in certain situations. But yeah, so what we do know is BFR accelerates fatigue, and that's important for people that are load intolerant, such as in rehabilitation. And what we're normally doing in rehab is we're doing, very light weights, and we're having our clients exercise, and we're trying to stave off what's called disuse atrophy, which is the condition that is most evident by visible losses in muscle mass, called atrophy. And when we have atrophy, when I teach, atrophy is yes, it's easily measurable in the clinic, but it's really a symptom of underlying local but potentially systemic dysfunction that happens, because muscle is not just an aesthetic organ, it's a metabolic anti-inflammatory organ. We need to do as much as we possibly can in order to maintain muscle mass throughout the lifespan. And that is why I've fallen in love with BFR, and I've fallen in love with exercise as a primary therapeutic target for my clients and patients, is because there's nothing that I can do that will benefit them more than keeping them active when they're having an injury or they're following surgery, or, even if they're healthy and they're having aches and pains. I want strategies to make sure that we can continue to stimulate the muscle adequately. And it just so happens that because of the unique stimulus of BFR, we are actually learning that besides just muscle, we are seeing that there are tendinous adaptations, there are bone adaptations, there are vascular adaptations, and even aerobic capacity adaptations. And all of these are a byproduct in some way, shape, or form from a localized temporary restriction in arterial inflow to an exercising limb.
Okay. Wow. So much to unpack here. First, you had to have a progression in this exploration of blood flow restriction training, or BFR. You began with straps in a tourniquet-like fashion. Then I can see probably utilizing some kind of blood pressure cuff. I mean, I donate blood every 8 weeks, and I know that they're looking for the veins and looking for the pumps, so they put the blood pressure cuff on to know where to insert the needle. Complete makes sense with what you're saying. But where are you now? We don't have to name brand names, but where the evolution of the cuffs that you use, are you using blood pressure cuffs, or are they much more technologically kind of advanced?
Yeah, I mean, I guess from the evolution of where I was at, it was straps at first, and straps are convenient at the time. Dr. Jeremy Lenicky, who I can consider now not only just a colleague, but a friend. He is one of the leading researchers in the world on the topic, and hit early on in his, I believe it was his master's work, they were looking at trying to use a more affordable piece of technology like straps, and quantifying that with a 7 out of 10 perceived tightness, and using that as a restrictive stimulus to kind of standardize it from application to application. Now, there are a couple of problems with that. And like any good scientist, Jeremy has walked back some of the proponent of being a 7 out of 10 tightness, predominantly, through the work in his lab, just saying that subjective assessments do not provide an objectively reliable stimulus. And that is hugely important. Maybe not as much important on the fitness side, but more important on the rehab side when we're dealing with medically compromised patients. I want to be as objective as possible with my application of blood flow restriction. Do I think that BFR is an extremely safe stimulus? Absolutely. I think that there are a lot of barriers to get over in education to make people comfortable with the idea of temporarily restricting blood flow. And that's my talk that I'm going to be giving in July at the NSCA's national conference. Basically, the main message is, if you can tolerate high intensity resistance exercise, you can tolerate blood flow restriction training. And that really, from a fitness side, opens the door for pretty much anybody that's walking through your practice to say, hey, BFR can be an option. Now, with that being said, I train, I would say about 50 to 60% of my caseload is actually long-term personal training with people that have sort of injuries that for one reason or another don't trust a trainer that doesn't have a doctorate in physical therapy. And I would say that of those, I probably use BFR maybe 5 to 10% of the time. Why? Because if you can lift moderate to heavy weights, why would you lift light weights with BFR, right? There are the traditional heavy load, moderate to heavy lifting is still the gold standard, will continue to be the gold standard. And that's why for me, it's kind of interesting to see that this stimulus, at least from the low loads in the traditional sense of studying BFR, has become more popular, or is becoming more popular in the fitness circles. Because I would be like, I always think about what is the easiest way to get the stimulus that we're trying to get for our clients, and understanding that BFR is not comfortable. And my research interests are, one of them is the amount of discomfort and effort that you need to put in to exercise with BFR compared to regular traditional strength training with moderate to heavy loads, or with the same exercise performed without BFR. And what we generally see is that BFR is just as stressful, if not more, than traditional high intensity strength training. And
Why?
Because, well, we don't necessarily know exactly why. I can theorize that it's, number one, we have more time under tension. That is, you're basically stewing in metabolic stress. So the difference between going to failure in 8 to 12 reps versus going to failure in 20 to 30 reps, or even more, is you're creating this metabolic stress that stimulates these unmyelinated group 3, group 4 afferents that surround the muscle, that detect mechanical and metabolic changes in the muscle. And that has a feedback loop into the central nervous system. And that feedback loop into the central nervous system increases, or it modulates the amount of discomfort that is experienced by the exerciser, but also tries to get blood flow to the exercising muscle, oxygen, right? So the longer that we're in there, the more that the metabolic stress is stimulating these afferents, the more that those afferents now are going back to the central nervous system, and you're getting, the exercise is getting harder to do. And not only that, it's getting more uncomfortable. And that is probably the reason why BFR is more, elicits more discomfort than traditional high intensity strength training. And then when we talk about work matched, meaning we're doing the same amount of repetitions in free flow compared to BFR, BFR outperforms or induces more discomfort and more perceived exertion. So it's harder to do. And that should make sense because BFR just accelerates that fatigue from accumulating. So you're basically comparing 1 rep to failure versus 5, 6, 10 reps to failure. And of course, as you get closer to failure, it's going to get harder and harder for you to do.
Oh, that makes complete sense when we're talking about high volume, low intensity, intensity being the load or amount that you're lifting. So, and now I understand why, like high intensity interval training, if you can tolerate that, like you said previously, that you could do BFR. So here's a question, Nick, is that of course we don't have organs in our appendages. There's no internal organs in our arms or legs. So we're not going to have any most likely adverse effect to there, but you are creating stronger appendages. How does that carry over into the trunk and the rest of the body? I mean, you're building these 4 limbs to get stronger. How is it that the torso, I'm not going to use the core, but the musculature connecting the ribs to the pelvis and so on, how is that affected?
Yeah, I think there's been considerable interest in what is termed proximal hypertrophy, and you basically described it in the sense that when we're having a cuff and we're putting it on the arm or the leg and we're exercising, but are we getting a benefit to the muscles that are proximal to the cuff? And I think that right now the evidence is very mixed, and it's something that is intriguing because I think that it would challenge some of my biases with respect to just the utility of trying to target your shoulder external rotators, but occluding or restricting blood flow to your arm or your leg. But I think there's a couple of things that we can logically assume given that example. And there's a recent paper that was just out. I haven't gotten a chance to read it. Ever since Sci-Hub has gotten the kaboot, I have not been able to get as many papers as I'd like to stay current. And if you don't know what Sci-Hub is, it's just basically a way that you can plug in a DOI and get the article back. It's kind of like publisher's worst nightmare, because all these paid articles are now getting released for free. But that had really kept me current for years on the BFR work. But nonetheless, basically, if you're doing shoulder external rotation and you have, the thought that it goes through my mind is, all right, well, we're working on infraspinatus and teres minor and posterior delt, right? Those are the three external rotators. None of them really have a large amount of muscle and or tendon that is distal to the cuff, right? Like the cuff is going to go on the proximal most part, so maybe partially some of the muscles tendon is occluded, but not a lot. But what is occluded are the biceps and the triceps. And what we do know is that just external rotation by itself wasn't really shown to be super effective or conclusive at producing favorable changes in the supraspinatus muscle, for example, or anything proximal. But when we pair it with more exercises that are targeting something like the biceps, or something like, through scaption or whatnot, we fatigue out one of the stabilizers. In this case, it would be the biceps. And thus it makes sense that if we take out one of the dynamic stabilizers, that it would force muscles that aren't as fatigued to work harder to now not only stabilize the humeral head, which is what the rotator cuff does, but also now perform the external rotation when we're asking it to do that in a resistance training exercise. So and that to me makes the most sense.
Okay, then in regards to program design, with that logical progression, you would do BFR training for say 6 to 10 minutes with low load to as temporary muscle fatigue as you can get, and then release the occlusions, take off the cuffs and straps, and then go through an integrative full body action so that those fatigue muscles can't assist nearly as much, and therefore recruiting a lot more of the trunk, torso, lower regions. I mean, do you do that, or do you stick with primarily open chain movements for the lower body, for the upper body, excuse me, like curls, push downs, dips, and so on, and then go to your squats, your lunges, and your deadlifts? I mean, what does it look like in terms of program design with BFR? What are the exercise selections?
I am very much biased toward, so I've been lucky to be mentored by Chris Beardsley. I don't know if you're familiar with who he is. He's probably one of the top strength scientists in the world. And he's really helped me with my blood flow restriction understanding and really breaking it down at the nuts and bolts, like at the myofiber level type. And so everything for me goes into how am I going to give my client the stimulus that he or she needs in order to get the adaptation that he or she wants. And for me, a lot of people come in and they want to get stronger and they want to get more muscle. So for me, if they're going to, knowing that BFR is not really tolerable, it's a really stressful stimulus. And it makes sense as to why, because you're really trapping those metabolites. You're creating a physiological stimulus that is beyond what would normally be done in practice. So like for me, my whole thing is why I always ask myself, why BFR at that point? Because it is so stressful. And it's weird me being the BFR guy coming on and saying, why don't do BFR? But if you're really healthy and you're able to lift moderate to heavy resistance exercise, I would do that almost 10 out of 10 times. I would say maybe 99 out of 100 times I would be doing that, because I'd rather people fatigue out and work hard for 25 seconds than it is for 6 to 10 minutes and give them a similar effect. Not to mention that, yeah, we have promising evidence for the similar tendinous, at least for the physical properties of tendons. We have new evidence that not only does muscle atrophy, but bone does as well. And the use of BFR following ACL reconstructive surgery attenuated or prevented the loss of bone. So we're seeing multiple different applications, but in reality, I don't see a ton from the resistance exercise side that's different than aerobic, mind you, because I do see more utility there in the healthy populations. But unless you have some sort of nagging injury that's preventing you from lifting heavy, or some apprehension, or if you just want to be punished, like if you want to punish your body from a psychological perspective, because it is a mental game at that point, you're really trying to push through a lot of discomfort, then I'm probably going to do BFR at that point. But otherwise, it's very difficult for me, given my understanding of what BFR does and the fact that it is normal strength training, just having a unique little spin. We're using what is in essence a tourniquet to be able to create these adaptations quicker than if we didn't use a tourniquet with low loads. And I think that all of the evidence that's been accumulating has now been mirroring what's happening in normal strength training. Like, we know that acute hormonal rises post-exercise does not correlate to longitudinal hypertrophy in untrained or trained individuals. And we now just recently, as of late 2021, have evidence to indicate that same exact phenomena does not exist with BFR, right? It shouldn't, because it operates the same way. And then we have reactive oxidative species that there have been something along those lines of like, oh, BFR, because, you're restricting oxygen, you're going to get a higher ROS, or reactive oxygen species response. And, we have a recently accepted meta-analysis that basically says that no, like, there is no difference between light loads and light loads of BFR in ROS. So we can't explain that hypertrophy with that. And then there's just a host of other things that are mentioned. Satellite cell proliferation, the designs of those studies are not conducive to making a strong statement and whatnot. So it's like, all right, well, if BFR just works like traditional strength training, I'd rather go within a modality or an approach. Kyle would kill me if he ever listens to this, me saying a modality, a technique, an exercise technique that just gets the job done quicker, and is like, that to me is like the no-brainer. And then you're not even layering on at that point. Nowhere in my decision making was a safety screening process, right? Like, but you have an external opinion, particularly with physicians that aren't as knowledgeable on the physiological changes of exercise, to understand that, like, we get occlusion at low loads anyways, intramuscular microvascular occlusion. So all we're doing is we're creating a little bit of a macrovascular occlusion in a way that we're reducing blood flow, but not nearly in the same magnitude as what they do during surgery, and not nearly at the same amount of time. And we're using a relatively wide cuff. So like, none of the evidence thus far really indicates that BFR is too stressful for exercisers of a variety of different, comorbidities. Like, I'll say one last thing is what really opened my eyes to the safety of the modality. I went to CSM this year, combined sections meeting, and that's the biggest physical therapy gathering in the United States. And there was a presentation from a group from the University of Miami, and they were having individuals in the intensive care unit doing blood flow restricted exercise. So if we're having people that are the sickest of the sick doing a blood flow restricted exercise and they're not having any negative responses, they're having perceptual problems, like people are like, this is too difficult, maybe I don't want to do this or whatnot, but they're not having safety issues. If they're not having safety issues, even in that controlled environment, and that's another, sidestep, but why are we worried about a relatively healthy individual walking into our practice as a physical therapy or the gym as a personal trainer, and like we're worried that we're going to cause some sort of super physiologic response? I just don't get it. And I think that the research will continue to show that safe, and it's funny that I use the word safe in the BFR is not unsafe, but I think that there are ways that we can maximize the safety in which we apply this modality or technique. Sorry again, Kyle. But I think there are ways that we can apply this technique that will maximize the safety of the approach. And that is what I'm interested in continuing to explore from an academic and research perspective, is what really matters when we apply blood flow restriction training. We already have a recommended pressure scheme between 40 and 80% of the pressure that it takes to completely occlude the blood flow to the limb. But now, besides that, are there any other features or ways to apply BFR that may maximize the safety, but also at the same time give us a similar therapeutic effect?
Sure. So I am curious, though, that the cuff sites being proximal happen to be very closely neighboring or on the lymphatic system. So any research pointing toward the improvement or degradation of lymphatic flow that you're aware of? I mean, by putting a cuff right on that site, does it, of course, it's very superficial. It's the lymph nodes themselves can be easily affected by the slightest touch. So to have a cuff there, any research that you've come up or seen regarding lymphatic drainage or just the lymphatic system itself?
No, I mean, I think the way to approach answering that question is first saying that there is none specifically on the lymphatic system, but they're using it on a variety of different populations that may or may not have impaired venous return, arterial inflow, or lymphatic flow. And we applied within whatever parameters they're using for their study, have not reported any sort of lymphatic issue. Now, we do know that the lymphatic system helps drain some of the swelling in the limb or following surgery. And we do have a couple of pieces of evidence that do show reductions in joint swelling following BFR exercise. And I think that for me, what makes the most sense in that explanation is we are creating such a venous backflow because we're occluding venous flow that we know the lymphatic system is closely connected to the venous system. So you're basically creating this fluid gradient that's almost pushing fluid into the lymphatic system, where when you're talking about traditional exercise, it might not necessarily have that same effect. So that's, believe it or not, a very uncommon question that I get asked. But I've thought about it. And again, it's tough for me to believe that a 5 to 10 minute application of a subocclusive stimulus is going to do anything really bad. I think where people have the misstep, and where I am going to spend some time in my talk in July, is underappreciating the impact that temporary ischemia can have on the first 1 to 3 exercise sessions in people that are unaccustomed to ischemic exercise, unaccustomed to exercise in general. I think that those two, but more so the person that is very sedentary and you're just starting them up on a new exercise routine, we have these cellular defenses that occur to help our body basically continue to exercise and withstand the stressors of, you know, a perturbation. And in this case, that perturbation is in the form of exercise. So we have, like, when we start to exercise, we get this, you know, in order to exercise, we have this release of calcium that goes in, and then that helps unlock the actin myosin through tropomyosin and whatnot. And we have this complex molecular signaling pathway that occurs to enable that to happen. But what happens is that calcium has to then come back and get sucked back into the sarcoplasmic reticulum. And when we have ischemia and we have exercise, that process kind of gets a little wacky, especially in unaccustomed exercisers. And the calcium that inside of the cell for a prolonged period of time can lead to degrading the cell's integrity, which can lead to muscle damage. And muscle damage, or excessive muscle damage, called rhabdomyolysis, which is a medical emergency, that to me is the biggest concern that I have with regards to the safety of BFR exercise in any population. It's unaccustomed exerciser decides, I'm going to do BFR, and they're going to do, not only, we didn't even talk about this, but the recommended protocol for BFR is 30 reps followed by 3 sets of 15, each with 30 seconds of rest in between. So you're doing 75 repetitions of an exercise. If you're unaccustomed to exercise in general, doing 75 repetitions of anything is probably going to already going to get you really sore and create some muscle damage until you acclimate. But where people kind of get, where I fear that people get overzealous is they're like, all right, well, we're now going to do, because we're doing no weight, right? You know, we're just going to have somebody do a body weight squat. Okay, but now we're just going to slap cuffs on. Well, now that ischemia paired with the inactivity and the lack of cellular defense mechanisms like upregulation of heat shock proteins, changes in the sodium potassium ATPase pumps to maintain the ion gradient that then allows, you know, all these other things that happen to make the muscle more resistant to fatigue and also muscle damage, they haven't happened yet. And I think that my biggest fear as BFR continues to spread is, right now we haven't had a ton of negative events in the research, reported or unreported or whatnot. I mean, that's another discussion. But as the public continues to adopt BFR more and more, my biggest fear is people have an overzealous adoption of this approach, and we start to see some, albeit small, I still think it's a small percentage, but a percentage of something is still a percentage. And I would like that to be as close to zero as possible moving forward as BFR continues to get adopted, particularly because BFR has a terrible name, blood flow restriction, right? That also is a triggering word for some people, I'd imagine. But yeah, I mean, I think that's kind of the biggest, my biggest safety fear is an inadequate initial prescription for BFR exercise. But the cool thing is that after you get through those, 1 to 3 sessions, depending on the client, right? I would say a deconditioned client, I probably will do more than 1 or 2 sessions of introduction type work with them to get them, comfortable, used to the BFR stress, progress them accordingly. But after that, you can basically go to town and you're fine. Like, I've had clients where I've done things that I've not done with any other people or tell anybody to do, like supersets, compound to unilateral to uni joint exercise, and barely walking out of the clinic, next day coming in just fine. And I think that there's a really cool, and that's kind of where I see the application of that in healthy people is if you're traveling and you don't have access to weights. If you've already done some form of BFR, then go at it. You're probably going to get a great training stimulus with little to no weight. Management of in-season athletes. They're afraid of lifting heavy weights, or they don't want to lift heavy weights because it might impede their recovery, add to their joint stress and whatnot. Or the use of BFR for some form of pain relief prior to lifting heavy. And that's another discussion in and of itself, and an evolving area of BFR is when we use BFR, we tend to see a significant local and a lesser, but still significant systemic response, meaning that if I have knee pain and I do a leg extension exercise, we tend to see a significant reduction in reported pain, but also response to a noxious stimulus or something that is not pleasurable. We see a reduction in that after, and even then we start to see it in like the traps. Like it's not as a big as the local effect, but there is still some ways in which, hey, you have a little bit of neck pain and you want to blast your legs with BFR, or heavy lifting does that as well, mind you. But if you decide to use BFR, you can feel somewhat cautiously optimistic that we can actually reduce some of the pain in your neck by doing BFR exercise. And that's probably the closest that I would ever get to saying that BFR has an effect that's not isolated to that particular extremity or proximal to the trunk in that same exercising extremity.
Right on. Well, fascinating. So yeah, blood flow restriction, not the greatest name. OT, occlusion training, maybe you run with that, see what that does. But how about this? You're going to be presenting July 12th to the 15th in Vegas at the NSCA National Conference. So for the listening audience, want to learn more, you can come and listen in on Nick, or online. They're going to be doing in-person and online as well. But also you've got courses. Tell me a little bit about the courses that you offer for BFR training.
Yeah, I appreciate the opportunity to share that. My second company is it's called the BFR Pros, and we are a BFR education company that I teach with a variety of different devices. I don't have any financial relationships with any cuff manufacturers, distributors, or whatnot. My interest is purely in the safe growth of blood flow restriction, and I am very proud of the fact that I practice what I preach, in the sense of, for example, like I've done BFR, I've done everything you could possibly do with BFR. In fact, I have BFR as part of my own rehab right now. I'm managing a stress reaction in my fibula, so I'm doing a lot of aerobic exercise with BFR to maintain my cardio. But I also publish extensively, and I'm trying to learn more about the good and the potentially whatever the bad might be. I'm always somebody to let science drive my thought process. And I think of any good scientist that should be driven by the data and not by their own personal biases. I admit I have my own biases, but you will see, if you've ever listened to any of my other talks, podcasts, or whatever, that I am very much biased toward pneumatic tourniquets, using air to be able to standardize the pressure, just because the current existing literature suggests that there is a pressure that we need to apply in order to actually accelerate that fatigue that we talked about. But I'm also involved in now designing studies with other cuffs that are not able to standardize the pressure that way. And they're marketed as being more safe because they don't occlude at all. They restrict, they technically restrict to occlude venous return only. And so, yeah, I'm involved in challenging my own biases. And, the big thing for me is, as long as BFR can grow safely and it maintains its efficacy that we've been seeing, then I'm all good. So I created a course with that in mind for the fitness and rehab professional, that goes over why we would use BFR and why wouldn't we might not want to use BFR. And I made it actually during the pandemic, with the, a 5 to 10 year window in mind, because research moves fast, but it doesn't move that fast to change the landscape entirely of how we're practicing blood flow restriction. So I made a 4.5 hour course that goes over the science behind the power of blood flow restriction training, and goes through all the different ways to apply it and the thought processes behind why you would apply it. And I think that's important because a lot of the times with things that are hip and new, it's like, I just want to apply it and continue to apply it and then figure out at that point who's good and who's not for that particular approach, right? And I do think that that has some merit, but at the same time, it's really important to have a rationale as to why you're doing what you're doing. And that course goes through all the ways to apply BFR in practice. And it's just as current as it was back in 2020. And we've also had a couple of updates to that course as well that are also included. So you have the most up-to-date information, and that's on bfrtraining.com. I also own bloodflowrestriction.com, believe it or not.
Nice.
Yeah, no, that was a good find. Surprised nobody else took it. But yeah, I mean, it's I think we have NASM and a couple other fitness body credentials. We had NSCA. I can't remember if we renewed or not. But nonetheless, if you're looking to get a very comprehensive but digestible approach to blood flow restriction training with no frills, and we spent a lot of money on that course. It's very high production value. We did that because, again, we wanted to have the best course on the market, and our reviews have stated as such, which is really, really nice and rewarding.
Congratulations. Okay, so for the listener and that is interested in exploring BFR training, obviously taking your course would be a very logical step one. Now, step two, acquiring the devices to use. Now, with your expert advice, and not, again, you're not affiliated with any specific brand or company, can you give us a couple of places that are good entry levels, or how would I get started? Where should I go?
Yeah, I mean, well, as part of the course, part of the bonus materials is, number one, a waiver and liability form, or liability release. I think that's important just because you have to always protect yourself. We're in a very litigious society. We paid a lawyer to do it. So in the United States, it should hold bar, even though, again, I don't necessarily think that BFR is unsafe. It's still something that is so new. You got to protect yourself. The second thing is we also added cuff discounts and where to buy these cuffs. And I think that there are, as technology has improved, and it's been improving really quickly. I would say 3 years ago, the only way that you could have applied BFR in my safely, in terms of that would fit in with my methodology, is to use an external Doppler. So a Doppler that you place on the vascular, the artery, and then you pump it up, and once you start to you don't hear it, then it goes away, and that costs like $100 a pop. But now there are more technologies that are out there that you're able to get your occlusion pressure wirelessly or through the use of another cuff. And I think that personally, I don't have problems naming brands. I think that Smart Tools has a good product. I think that they're about to release their next gen product, which I'm very excited about. I haven't gotten a chance to put my hands on, but that is all wireless. I've heard and experienced a variety of negative and neutral comments with, things, a cuff called the Air Bands. They also go by Saga Fitness. I think that their cuff is good for an entry level. If you're okay with the potential for there to be Bluetooth connectivity problems, I mean, you get what you pay for, is basically what it is. But they're recently been validated, which is important, meaning that whatever the algorithm gives you, that's actually the correct value in terms of putting your applied pressure on, at least in the upper body. In the legs, a little iffy. And then there's other options that are manual pneumatic, that may have like a different varying abilities to determine your personalized pressure. Fit Cuffs has one of those types of applications, and they're a couple $100. I think all of those cuffs that I mentioned are going to be on the order of a couple $100 to, depending on how many you want, like mid 1500s. So it's not super cheap, but it's definitely better than using a strap or something where you can't really measure the amount of pressure you're applying. I do think that that's an easy, very easy, like thing to dodge. Like when you're talking about safety, right? Like it's like, how can you make things unsafe? Well, the first thing is, I don't know what pressure I'm applying to the person, right? Like it's an easy one to dodge. You get a cuff that can apply a pressure that's going to be subocclusive, and that you can then use that as part of your programming.
Oh man.
So we have discounts available there. Again, I don't get any money for any of those. It's just, I just am the middleman of trying to make sure that whoever is using the cuffs, they actually have a good foundational knowledge of BFR. And at that point, it's just practice with the appropriate people.
Right on, man. Nick, I just thank you so much. This has been so informative, so educational, and I feel like I'm just now scratched the surface. I've got so many more questions. How about this? We're run out of time, and I don't want to take any more of your time right now. My hope is that we can connect in July in Vegas in person, and maybe a few months down the road, maybe this fall or winter, we could maybe have you back on and we could talk some more, because I got all these questions about pressure and blood pressure varying based on the person from day to day. And anyway, we'll jump into that another time, but I can't thank you enough. One last question. People want to follow you. You do post. And so in regards to social media, troll free, where should people be going?
I have an Instagram. I have two. One is the BFR Pros. That's just the company Instagram. And then I have my personal and professional for my physical therapy personal training clinic. That one is I'm way more active on. It's just the THE and then HPM, the HPM on Instagram. And anybody listening, feel free to send me a DM if they're interested in taking the course, and I'll hook them up with a discount. Just tell me that you listen to this podcast, and I will get them that discount. And I appreciate the opportunity to come on and babble a little bit about BFR. But yeah, I mean, you can see how it's kind of just a peek into the field of BFR and the potential applicability in a variety of situations. So thank you for the opportunity to chat.
My pleasure. Sitting on the tip of the iceberg. And that's a wrap for this episode. Man, I think I need a cold compress. My brain is hurting. There's so much information in there. Play it back a few times, slow it down, because, man, Nick gave us a lot to think about. Hope you enjoyed it as much as I did. In the meanwhile, be sure to click subscribe. Ray, leave a comment. I want to know how you guys are enjoying the show, and share it with other people. And we'll see you next week.